Good morning, everyone. Thank you so much for your patience as we get rolling this morning. We just had a couple of technological issues that we had to adjust on our rocket ship before we launch, as it were. So thank you so much for your patience. We are going to get started right now. My name is Paul Carson, and I work with CareOregon. I'm happy to welcome you to this edition of Pharmacy Department's Meds Ed program. Meds Ed is an educational series that we host throughout the primary care networks across the state of Oregon, and it typically focuses on chronic diseases and other types of health conditions that impact the lives of our members here in the state of Oregon. So we're excited to have you all here. We're going to get started right away. Today's topic is perinatal prescribing, substance use disorder and behavioral health meds, and how to manage those effectively during pregnancy. A lot of times what we continue to observe in the lives of our members that are experiencing these conditions is that when pregnancy becomes part of the situation, everything changes. And there is kind of a well-intentioned tendency to grab the emergency brake and just kind of stop the vehicle right then and there. And it's those sudden stops in terms of medications that we have to be aware of. Because while those sudden deprescribing events can be well-intentioned, a lot of times what we've seen is in the realms of SUD and behavioral health, the unintended consequences of those sudden starts can be worse than what we might anticipate in our good intentions that will actually occur. So we've got experts here to help us navigate this today and provide a lot of really great guidance for you in the primary care environments to help be able to understand what's safe to do and what should be avoided. I think the clarity here is going to be really helpful for you. Just a couple of minor housekeeping things and we'll get started. Here's this morning's agenda in terms of how much time you should expect the two segments to occur. We're going to try to plow through today without an actual formal break, just so you know here. About 2.5 hours of total content for CME and CEU. There will be a panelist Q&A segment where both of our presenters will be able to answer your questions today at the end of the segment, so we got a lot of time carved out for that. At any point during their presentations, if you have questions, anything that you want to be able to ask them, just go ahead and put it in that chat Q&A area there, and we'll collate those and provide those to our presenters, and we'll deal with those as they occur, because lots of questions are bound to happen as you're reacting to the content. So thank you for your patience with that. Basically, these are the overall learning objectives for our content this morning. Understanding of substance use disorder medication safety during the perinatal period. Likewise, behavioral health medication safety during the perinatal period. And understanding of negative outcomes that occur during pregnancy when these types of medications are deprescribed. So that's a real piece of our focus. And then the two different topic segments today from our presenters will have their own little sub-learning objectives as well. But this is the main focus that we'll be taking care of here today. A lot of folks are interested in getting hours for CME or CEU credit. This course is filed for 2.5 hours today, both through the American Academy of Family Physicians and National Association of Social Workers, LCSWC credits. These do also apply for pharmacists as immediately recognized credit for your CE hour requirements at renewal. If you have any questions about that, just let me know. How we do it is at the very end of the segment here later this afternoon, I'll be sending all registered attendees a survey via email. Super quick. You just go ahead and respond to that. That logs your attendance, attests that you were here, and we'll make sure that you get your statement of credit. Simple, easily done. So let's go ahead and move forward here and we'll start our presentation. And I am super excited that we have our two guests with us here today. I think you're about to be exposed to some really great content that's going to provide a whole lot of clarity. Our first presenter this morning is Dr. Kerri Hecox, a primary care physician who's board certified in both family medicine and addiction medicine. She is the founder and medical director of the Oasis Center of the Rogue Valley, a clinic which specializes in the care of pregnant women and families with young children who struggle with substance use disorders. It's my great pleasure to introduce Dr. Kerri Hecox. Doctor, take it away.
Okay. Thank you, Paul. I appreciate your introduction. So today I'm going to be talking about substance use disorders in pregnancy. And goals for our talk are really an overview of substance use disorders, how they affect the brain and thinking, which I think is a really critical point. Barriers to care unique to substance use disorders in pregnancy, a little bit about gender differences in substance use, and the importance of appropriate prescribing of medications during pregnancy, particularly for common use disorders. So the first thing I like to talk about when I talk about substance use disorders is they really do change the way people think. And so I'm going to read a couple of quotes from an addictions researcher named Thomas Gould. The brain regions and neural processes that underlie addiction overlap extensively with those that support cognitive functions, including learning, memory, and reasoning. From a psychological and neurological perspective, addiction is a disorder of altered cognition. Chronic amphetamine and heroin users show deficits in a range of cognitive skills, including verbal fluency, pattern recognition, planning, and the ability to shift attention from one frame of reference to another. The decision-making deficits resemble those observed in individuals with damage to the prefrontal cortex, suggesting that both drugs alter function in that brain area. So I'm going to talk a little bit about why that is and why that's really important when we're caring for people with substance use disorders. Addiction really hijacks the reward pathway of the brain. And that reward pathway is extremely important in cognitive function and decision making, because it's really a pathway that is very primitive and evolutionarily very basic to our functioning. I'm going to talk a little bit about that. So what is the brain reward system? So the most important reward pathways in the brain are in the mesolimbic, the dopamine system. And I think most of us are aware of dopamine as being very enforcing, or we talk about it as the pleasure neurotransmitter. The circuit that dopamine really acts strongly on is the ventral tegmental area and the nucleus accumbens. And the nucleus accumbens is really a key detector of rewarding stimulus. So under normal conditions, that area controls our response to natural rewards, food, sex, social interactions. And if you think about it, those are all things that are either key to the individual staying alive or the species staying alive, right? So it makes sense that those would be rewarding behaviors from an evolutionary point of view, because you want to do things that keep you and your species alive. So it's a very basic reward pathway. So dopamine neurons have been shown to mediate behaviors in responses to natural rewards in worms and flies. This evolved 1 to 2 billion years ago. And all mammals have this, the ventral tegmental area, the nucleus accumbens. So rats, horses, dogs can all be addicted to things because they have this same reward pathway that can be overtaken. So it's a very fundamental pathway evolutionarily. Because of that, this system is really tied strongly to memory and learning. So the VTA is the site of the dopaminergic neurons, which tell the organism whether an environmental stimulus is rewarding or adverse. Is this something that I want, behavior I want to repeat, or is it something I really need to avoid? And the nucleus accumbens really affects that, how that signal is interpreted. And all drugs that cause addiction or dependence go through this pathway. So as opposed to the hallucinogens, so mushrooms, LSD, those affect the serotonin pathways. So people really cannot get addicted to those because they don't go through this reward pathway. It's really drugs like methamphetamines, heroin, opiates that affect this pathway. And this pathway is really important for conditioned forms of learning. So it helps an organism establish associations between environmental cues and a rewarding experience. So your brain, when you're exposed to a natural stimulus or to a drug of abuse, your brain is laying down memories of everything that surrounds that experience. Okay, so it really changes the wiring of your brain. So, and why is this so important when we're talking about addiction? Because the reward system of the brain is subconscious. You know, often we talk to people who are in addictive patterns and they'll say, I'm not going to do this anymore. I am so done with using that drug. It's ruined my life. But that's really speaking from their conscious brain, from a more advanced part of their brain. And this system is really a subconscious system that filters the way we see the world, right? And it's so integral to survival, it can really overwhelm our conscious thought process. So an example I like to give is food is essential to survival. Think of a time when you were really hungry. You might be able to decide not to eat, but could you tell yourself you weren't hungry? And how did it affect your mood? I think we've all heard the phrase hangry. I'm hungry and I'm angry, right? Because it affects our emotional state pretty significantly. Addiction dupes the brain into feeling like it's starving. So how do drugs of abuse do this? So if we go back to that dopaminergic pathway, drugs of abuse essentially give a much larger rewarding stimulus than our brain was really designed to understand. So if we look at, say, baseline in the brain, dopaminergic function 100%, food 150, sex 200%. That's about where our brains were designed to interpret reward, right? If you go to amphetamines, methamphetamines, heroin, so methamphetamines 13,000 times 1,300 times the baseline dopamine. And so basically what this tells your brain is, on a very neurological fundamental level, wow, I really need this to survive, and I'm going to remember everything about this experience because it's so fundamental. So that's not what the person's conscious brain thinks, but on a very basic level, that's what's happening, and that's what's affecting their filter and their interactions with the world. So when a person stops using these drugs of abuse, the analogy that I like to use is that it's like they've been listening to the world at about 120 decibels, right? They've been getting this abnormally high, very abnormally high levels of dopamine. And then suddenly when you take those away, they go back down to baseline, which feels like it's so much less than they had been experiencing before. And this really affects their emotional states. So anxiety, depression, trouble sleeping, tired all the time, and difficulty concentrating. I would say those are the 5 things that I see in almost everyone who's in that early stage of recovery. And so how does this affect a person's reactions to certain situations? Essentially, they function at a lower level in the brain. And I'm going to go talk a little bit about brain physiology and what areas of the brain control different responses. So the prefrontal cortex is really the most developed and complex part of our brains, right? It is where all of the stop mechanisms really come with behaviors. So inhibition of inappropriate actions, regulating emotions, reality testing and error monitoring. Do I want to do this? Or if I do this, if I'm really mad, if I yell at this person, is that going to help me in the long run, right? Should I just back off and let it go? Or do I really just want to yell at that person? So that kind of reality testing. So if we're in a calm state, and our prefrontal cortex has control of our brain, we're able to do that. Reality testing, error monitoring. Okay, do I want to make this choice or that choice? And we're a lot more future oriented. What are our actions going to affect? If we're in a dysregulated state, so if we're in an emotional state where we're under a lot of stress, we really lose that prefrontal regulation. So we're coming from a much deeper part of our brain. So that if you look there, the nucleus accumbens, emotional reflexes, emotional associations. We start coming from this part of our brains where it's all about immediate action, and we can't really do the same error testing that we would if we were in a more regulated state. I'm going to go back. I like this. I'm going to go back to this slide. This is a slide from Dr. Bruce Perry. He's a child psychiatrist who's done a lot of research in how trauma affects children and their functioning. And I think there's a lot of relevance to his models with people with substance use disorders. So he visualizes the brain as like basically an upside down triangle. And if you look at the cortex, the prefrontal cortex, that's where all of our abstract thought comes in, our future orientation. As we move down in the brain, you know, to the limbic system, we're more focused on emotional cues, dysregulated behavior. Going deeper, you have motor, your motor regulation, arousal, and sleep. And then when you get down to the brainstem, it's really your basic functioning, like your blood pressure, your heart rate. And depending on what state of emotional arousal you're in, you're really working at different parts of your brain. So this is again Dr. Perry talking about, you know, how much of your brain are you able to access in a calm state. So if you're in a calm, regulated state, you're really able to access your neocortex to a large extent. So in doing that, you're able to do error testing, future orientation, really gauge decision making and think about what's going to be beneficial in the long term. If you're in a dysregulated state, if you're in a very emotional state, you really can't access that future learning. And if we think about this, you know, think about high risk professions like airline pilots or fire. What happens in those, there's a lot of safety drills done in high pressure environments, right? Because making a high pressure environment familiar or something that someone can identify keeps them from going into that highly dysregulated emotional state, because they're much more prone to making errors if you're emotionally dysregulated, right? And so that's where drills come in, you know, safety drills with high risk professions are really common so that people can stay regulated in high risk situations and make appropriate decisions. This is again from Dr. Perry, and he puts in, you know, he visualizes this as if you are more dysregulated, you really become stupider, that you can't make the same complex decisions because you're simply not able to access those parts of your brain that lets you really make those subtle risk and reward calculations. And this is very relevant to people in the midst of substance use disorders and in the immediate period following when they're in recovery. I'd like to bring this up because I think it's really important when we're talking with people who are in an addiction, that they're really not thinking the same way that that perhaps we are. And it's really based in physiology. Like, why would you drink when you're pregnant? Or why would you use when you're pregnant? That makes absolutely no sense. That's horrible. It's not coming from someone's, really, when you talk to people, it's not coming from their conscious brain and long-term decision making. It's really coming from this reactive area in their brain where they feel like they need to do this in the short term. So I'll talk about that a little bit more when we're talking about screening for substance use disorders in pregnancy. So there are really different gender patterns with use disorders. Women tend to have a shorter history of using substances before entering SUD treatment. However, they typically have more severe medical, psychological, and social issues when they enter treatment. Women really have a quicker progression from first use to becoming dependent on a substance. So someone going from a recreational user and, you know, just experimenting with different substances to becoming dependent on it, women are much more likely to progress quickly. We have a term for that. It's called telescoping. With alcohol use disorder in particular, relative risk of progression is cirrhosis in men is 7 times. With women, it's 17 times. So there's some biological differences in women that make them more prone to having more severe substance use disorders more quickly. Also, women face unique barriers to accessing treatment. Many women who are pregnant who have young children don't seek treatment or drop out because they're unable to care for their older children. And the shame and stigma involved in accessing treatment for pregnant women really can't be underestimated. Most women who are actively using that I deal with are so ashamed, and they feel so terrible about being in that space. It's really hard for them to talk about and to seek care because they fear the judgment. They're already judging themselves so much. They're going to see that in the medical system, even with someone who isn't particularly acting judgmentally towards someone, because there's such a huge pressure in the minds of these women. It can really be a difficult and traumatic experience for them. And I'm going to talk a little bit more about that in some following slides. Women may fear that authorities will remove their children if they access treatment. That's child welfare is a big fear for many women. And a big reason why they don't seek treatment is because they're concerned that child welfare, with a pregnancy in particular, that child welfare is going to come to the hospital and take their baby. And that's a real barrier with seeking treatment. Also, a lot of women have all of these other responsibilities to family members, taking care of other children. So really successful treatment isn't just about the medications. That's actually a really small part of it. A big part of it is making sure that people have social supports. They have transportation, they have access to childcare, they have some emotional supports. Those things are really key to someone being successful in recovery. Pregnancy is a unique time in a woman's life, and I think of it as a real moment of change for most women. I don't know, I can't think of a single person who I have cared for who has wanted to keep using an illicit substance during their pregnancy, from their conscious thinking brain. It's really a point where I think most women are trying to make that behavioral change, but it's so difficult that it's a real battle within their own brain, really. So motivators are, most women are really ready to stop using when they're pregnant. They're concerned about their baby's health. They're concerned about custody. A lot of times there's other social factors with women who are using. Domestic violence or being in a controlling relationship with a partner is very common. Barriers are the fear of losing custody of their children, stigma and shame, not wanting to be away from a partner. But I think the stigma and shame are really probably the biggest things that keep women from accessing care during pregnancy. And I think it's important to realize that motivators and barriers are a dynamic process. Some of the things that I see when I'm caring for women with substance use disorders, they'll come to an appointment, and I think of it as like surfacing. They're coming in because they really want help. And if we can't provide the help really when they're coming up, a lot of times they're kind of brought back under, and we'll kind of see them intermittently during the pregnancy because they're motivated, but then they have all these other barriers. So it's a really dynamic process, and really takes a lot of support to move women so they can get the help that they need. So I'm going to talk a little bit about screening tools for pregnancy. What I would say with any screening tool, it's not what you say, it's how you say it. And I would really emphasize, I think that written screening tools, in my experience, are not very helpful, because thinking about where a woman is coming from, if she is using a substance or using alcohol, to write down on a piece of paper that you are using this is, you don't know what the reaction is going to be on the other side, right? And so I would say it's very difficult for someone to check a box about these really emotionally loaded questions. And if you use these screening tools, using them with a live person, I think is important, and also doing it in a way that's really non-judgmental and supportive. So really opening that space, like if you do have a problem, let's talk about it. Because people are women, particularly in pregnancy, are very fine-tuned to even subtle feelings of judgment and stigma. So they're going to be much more aware of your body language, the way you say something, than, let's say, screening for high blood pressure or whatever else. I mean, it's such an emotionally charged topic that really thinking about how you're going into that screening and how you're talking to someone is really key to being able to help them access care and access the help they need. So these are just a couple of screening tools, the 4 Ps plus, the integrated 5 Ps. This is the Institute for Health and Recovery integrated screening, which really looks at risks for domestic violence and mental health evaluation. Again, I think that is really, these screenings are really important to do verbally with people and really open a space, because domestic violence is another area that commonly co-occurs with substance use disorders and is very difficult for women to talk about. This is just a side note. If you are caring for pregnant women with use disorders, hepatitis C is not standard in many prenatal panels. It's really important that women be screened for this. Hepatitis C is very common, particularly with people who use IV substances in Oregon. So I'm going to go a little bit before we go into the medications about child welfare and reporting response, because, you know, as I said, so much of this is not the medications, it's the social environment that people are in, and really the emotional milieu that which we approach this issue. So child welfare reporting currently in the state of Oregon, and this varies state to state, which is really important to know. Child welfare, if you do have a woman who is using during pregnancy, they want you to call the hotline, but it is not registered as a child welfare issue, because this is the child isn't born yet, so it is not considered a child welfare case or a child welfare report until the baby is born, and child welfare isn't necessarily going to go out when this child is born, just because of that report. And so I think that's something to reassure women about. If we talk about this, really the way reporting is now in Oregon is really just for record keeping. It is not going to trigger an automatic child welfare response to the hospital. So really encouraging women to seek care, even if they are actively using, is important. It's not going to affect how child welfare responds in the hospital. Child welfare, when they get to the hospital, are going to look at what's going on in that moment when the baby's born, and if it's a safe environment or not. And this is different from other states. There's a few states that have mandatory reporting and can have civil commitment related to women using in pregnancy. There's actually 3 states that have civil commitment laws, but Oregon is not that way. And I think, you know, talking to women early about that is really important, because this is a big reason they're not going to come back if they think you're going to report me. So risks to substance use in pregnancy. Many have not been well studied, and the reason for that is that there's so many confounders with looking at substance use in pregnancy, because, you know, when a child has been affected by substances in utero, often after they're born, there's a lot of environmental issues. They go to foster care, they're in an unsafe environment. It's really difficult to tease out to what extent each substance causes a certain disorder. The one exception to that is alcohol. Alcohol is clearly documented as a significant teratogen. There is no question about that. Smoking, very common in patients who have substance use disorders, risk for low birth weight, higher risk for sudden infant death syndrome. Children born to mothers who both drank and smoke beyond the first trimester of pregnancy have a 12-fold increased risk for SIDS compared to those who were unexposed or only exposed in the first trimester. Neonatal abstinence syndrome, I'm going to talk a little bit more about, is a short-term effect of opiate use. And the effects of methamphetamines and marijuana really likely have longer-term developmental and cognitive effects, but we don't have, as I said, those are really difficult to study. So really, of the drug use in pregnancy, from my perspective, alcohol, I mean, obviously, I'm concerned about any woman using substances, but alcohol has very, very severe and immediate adverse effects. I'm going to get to the medication part of the talk, which is what we're here for, the meds ed. Opiate use disorder in pregnancy. And so opiate use disorder in pregnancy can be anything from use of prescription medications used incorrectly, oxycodone, can be heroin. Recently in Oregon, we've seen a huge increase in patients using fentanyl, which I'm going to talk a little bit about, which has really kind of changed the landscape for opiate use disorder and made it really much more difficult to treat. So the medications that we can use for opiate use disorder in pregnancy are methadone, buprenorphine, the mono product, Subutex, the combination product, buprenorphine and naloxone. That I'll talk a little bit about the differences between buprenorphine and buprenorphine naloxone in a moment, but I think the Suboxone combination product is getting used much more regularly in pregnancy now. Naltrexone as a possibility, and then Sublocade depo-buprenorphine, which is not approved for use in pregnancy, but the depo-buprenorphine has a lot of interest in are there formulations which we might be able to use. So this is just a plug for a very good website. It's a subscription service, ReproTox. It's kind of the medications in pregnancy equivalent to UpToDate. I think of it, they do regular surveys of the literature and what the latest studies are, and kind of quick takes on medication safety in pregnancy. I use this all the time. I find it really helpful. So medications in pregnancy, or for opiate use disorder, methadone. So methadone has been the gold standard for opiate use disorder treatment for a long time. So the latest ACOG recommendations are that either methadone or buprenorphine are first-line therapies. Methadone, compared to buprenorphine, has a slightly higher success rate with patient engagement. One of the benefits of methadone is that buprenorphine is a partial agonist, which I'll talk about in a sec. Methadone is a full agonist opioid. And so the advantage of that with people who have significant dependence on opioids is you can increase the dose in order to get to a level that's really helpful for a patient and is able to suppress their cravings for other substances. I think particularly in the current age with fentanyl use disorder, we're seeing a lot more women who need to go to methadone rather than buprenorphine, and I'll talk about that when I talk about fentanyl. Methadone can only be prescribed by licensed opioid treatment programs. So that is sometimes a point of confusion for people, that you can, if you're a prescriber, you can prescribe methadone for pain in the outpatient setting, but you cannot prescribe it for opiate use disorder as a diagnosis. That's illegal. So the only places that methadone can be accessed are opioid treatment programs. And those it's a system that has actually quite a number of controls around it. So for example, you have to go through an intake process. For most people, they have to show up daily to get methadone for the first 90 days, and then they start getting takeouts. So even though it's a very effective medication for opioid treatment, and there's no risk of precipitated withdrawal. So precipitated withdrawal is when someone's on a full opioid and they're given a partial agonist opioid like buprenorphine. It can cause adverse effects. Methadone as a full agonist, there's no risk of precipitated withdrawal. The issue with methadone for most people is it's really difficult to access. And if we think about some of those barriers that I had talked about before, childcare, transportation, people who are, in unstable living situations, getting to a methadone clinic every morning can be really, really difficult. So in my population, I think that's the biggest barrier, that people just don't want to do it because it's so difficult. And also there's quite a bit of stigma around methadone. So methadone compared to buprenorphine, there's higher rates of neonatal abstinence syndrome with methadone exposed neonates than there is with buprenorphine, but there's no correlation between the dose of methadone in pregnancy and neonatal outcomes. So higher doses of methadone don't necessarily mean the baby is at higher risk for neonatal abstinence syndrome. It's really the physiology of the fetus that seems to be the big issue, and it's not a dose-dependent adverse event. Buprenorphine also, there's no dose dependency in neonatal abstinence syndrome, and I'm going to talk about what that syndrome is in just a moment. So this is just a little bit, this was a big study. Actually, this was one of the mother study was done in 2012, and it really established buprenorphine as a first-line treatment for opiate use disorder in pregnancy. And I won't go too much into it, but essentially very equivalent outcomes between methadone and buprenorphine, slightly higher rates of neonatal abstinence syndrome. Oops, sorry, I went the wrong way. So buprenorphine monoproduct, so that's Subutex. So methadone was considered, as I said, the first-line therapy prior to the mother study. Subsequent research has confirmed that buprenorphine is a safe and viable option in pregnancy. The initial studies on buprenorphine were done with the monoproduct with Subutex, and therefore accumulated more safety data. So for a long time, when we first started using buprenorphine in pregnant women, we would just give them Subutex rather than Suboxone. There's been several studies that have come out since then that have shown that use of the combination product really does not affect fetal outcomes. As I mentioned previously, the dose of buprenorphine doesn't correlate with the risk for neonatal abstinence. Although we are using the combination product quite a bit, the latest SAMHSA, which is the Substance Abuse and Mental Health something agency, and the CDC both recommend the monoproduct as first line. However, there's been several studies coming out that have indicated that the combination product is equivalent to buprenorphine alone, no risk in congenital abnormalities. Animal studies have not shown any adverse effects of naloxone during gestation, even at very high doses. And the latest ACOG position statement, which is from 5 years ago now, is that the use of the combination product during pregnancy will likely expand as more safety data are accumulated. In my practice, I use it a lot. If a patient would really prefer to be on the mono product, I'll use that. But generally, I will use the combination product if I can. The long-acting injectable buprenorphine, the only product on the market now is Sublocade. There's not a lot of data on this. There was one case report that I found of 2 pregnancies that were exposed to Sublocade in pregnancy, and they didn't have any adverse outcomes. However, the issue with Sublocade is the carrier agent, and Atrogel, which is the carrier agent in Sublocade, has been shown to increase pregnancy loss in animal models. It's unclear at this time how generalizable it is to humans. There's another injectable buprenorphine that's in development now, Brixadi, that has been recently approved for marketing, and there's a study going on at OHSU around this product being used in pregnancy. I don't know where that study is. I think it's ongoing, but that might be in the future a viable option for pregnant women. Right now, we are not using Sublocade because of the potential risk of the carrier agent and whether that might induce birth defects or adverse pregnancy outcomes. Naltrexone. So this is a medication that is a full blocking agent, and I really should have done a slide. Now that I'm doing the talk, I should have done a slide about the difference between full agonists, partial agonists, and blocking agents. So methadone is a full agonist. Buprenorphine is a partial agonist. Partial agonist means that once you get up above about 24 milligrams, you don't get any more effect from buprenorphine. So larger doses don't necessarily confer more benefit, which makes it really a safer drug than methadone because you can't, I mean, you could overdose on buprenorphine, but it's very, very rare. Usually the overdoses that have been documented are mixed with other substances. Naltrexone is just a blocking agent. So essentially there's no reinforcing effects with naltrexone. It simply blocks the opioid receptor. We don't use this much, at least I don't use this much in opiate use disorder. I do use it with alcohol, which I'll talk about a little bit later in the talk, because it's very difficult to get onto naltrexone from using full agonist opioids or even partial agonists. But basically you have to have a full washout of whatever opioid the person is using, and they have to be off all opioids for 10 days, which for most women, for most people, isn't realistic. That's a very difficult withdrawal to go through. So I would say this is not a first line at all in pregnancy or really in opiate use disorder in general, except for the very highly motivated patient who really does not want to be on any kind of agonist therapy. And this would involve really someone going through a detox program, being off opiates, and then starting naltrexone. So that being said, there have been some studies done with opiate use disorder and naltrexone. There was a recent study of 230 pregnant patients comparing oral naltrexone to standard MAT with methadone or buprenorphine, showed no difference in birth outcomes. Oral naltrexone is not approved for opiate use disorder. It's approved for alcohol use disorder. Really, the injectable naltrexone would be in opiate use disorders, not the oral formulation. There was another study in Australia talking about pregnancies exposed to the implant naltrexone compared with methadone. So this is an implant similar to the injectable. There were some higher rates of ectopic pregnancies, but otherwise equivalent birth outcomes, no teratogenicity in animal models. So really not recommended therapy at this point with opiate use disorder, but it's being done and studied. For your patients who are on agonist therapy during pregnancy, there's a question of should they be maintained on the medication during the pregnancy, or should they have a withdrawal, basically be tapered off the medications? And I think in the patient population that I see, oftentimes women, if they've been stable on the medication for a while, will want to come off of it because they're worried, particularly if they've had a prior pregnancy where the baby's had some withdrawal symptoms or had neonatal abstinence syndromes. They don't want to repeat that. The recommendation really is to maintenance, to keep women on whatever agonist therapy they're using during the pregnancy. However, that being said, maternal detoxification is unlikely to cause miscarriage or fetal harm. I think a few years ago, we thought coming off these medications and going through the detox process would put women at higher risk for preterm births or miscarriages. Really, that has not been shown to be the case. There's a meta-analysis of 15 studies with over 1,000 women who went through detox during pregnancy, and they didn't show increased rates of fetal demise or miscarriage. So I would say the decision needs to be individualized to the patient. And in my mind, a patient who is been stable on medication-assisted treatment for several years, this is a planned pregnancy, they're in a very stable place, I think it's reasonable to look at tapering them off the medication. If they're done it, with a full risk and benefit. That's a very different clinical scenario than a woman who is really early in recovery and who is likely to be at very high risk of relapse. In that situation, I think really steering them towards staying on the medications is really important, but working with the patient and patient autonomy and choice is really important in these situations, like respecting where the patient is coming from and what they think is going to be best for them in their pregnancy. So I'm going to talk for just a minute about fentanyl, and I don't know how much the attendees at this talk are seeing with fentanyl, but over the last year here in Medford, we have seen a deluge of this drug, so much so that we really are seeing very little heroin anymore, and we're really seeing people who have moved to the powdered and the pressed pill form of fentanyl. I can count on one hand in the last month people that I have seen who are still using heroin. It really seems to have just really gone to fentanyl, which is quite unfortunate. Fentanyl has some characteristics that make it really different. It's a different drug and it's a different withdrawal pattern than what we had seen in the illicit market previously with heroin and oxycodone. It's a very high potency drug and it has a relatively high binding affinity for the mu receptor. It's also, and this is probably the most important point, it's a short-acting drug on its own. So licit fentanyl or pharmaceutical-grade fentanyl is used in surgeries, and it tends to be very a potent, short-acting pain medication. However, in people who are using it consistently at high levels, it has a high lipid solubility. And so it's stored in body fat for longer periods of time, similar to THC. So people who have been using this drug consistently get this very large reservoir basically stored up in their bodies that makes it much more difficult for them to withdraw from it and much harder to start buprenorphine in particular because of, one, it's got a fairly high competitive binding at the mu receptor to buprenorphine, which also has a high binding affinity. So fentanyl withdrawal has more prolonged withdrawal than heroin and has some different symptoms. I've been seeing a lot of variability in the severity and duration of withdrawal. And the theory is that it's the saturation of the fat in sustained users leads to this longer release, like over days. When we were primarily treating heroin, you would have someone who would come in, they would be off heroin for 16, 18 hours. They would be getting your traditional opiate withdrawal symptoms, body aches, nausea, vomiting. We could give them buprenorphine at that time and they would turn around and feel better. That's not what we're seeing with fentanyl. It's much more difficult to get people onto buprenorphine, and we're still really, in the addiction medicine world, struggling to find the right protocols to transfer women onto, or patients in general, onto buprenorphine, and we're seeing a much higher rate of people really needing to go to methadone. And the other piece, I think, is that there's a myriad of fentanyl analogs that are starting to come up in the urine drug screen, so like 4-ANPP, that have all of these different durations of action and binding affinities. So that's really made the landscape really different and challenging recently. So as I said, because of the difference in withdrawals, it's more difficult to start buprenorphine. There's no consensus in the medical literature yet on how to do it. Clinicians are trying both very low dose initiations of protocols, so microdosing it's called, and then rapid high dose protocols. Neither one of these approaches is perfect. It's really an area of ongoing study. This is kind of a whole other talk in itself. Fentanyl's really changed the landscape, and it's been difficult. So I'm going to talk a little bit about opioid withdrawal, neonatal abstinence syndrome versus neonatal opioid withdrawal syndrome. Really, I think most people use these terms interchangeably. The nows is becoming more common, but technically neonatal abstinence syndrome is withdrawal from polysubstance exposure, including opioids, and NOWS is a withdrawal pattern specific to opiate exposure. I would say that most neonates with illicit opioid exposure also have polysubstance exposure. And really, yeah, we use these terms pretty interchangeably. So what is the NOWS or NAS syndrome? So estimates range that 55 to 94% of exposed neonates who have had some chronic opioid exposure in pregnancy will develop a withdrawal pattern. As I mentioned before, the use patterns does not correlate with the neonatal withdrawal. So people on high doses of methadone don't necessarily have a baby who has more symptoms. But basically what happens with this syndrome is babies struggle to function in key areas, which is being able to eat, being able to sleep, and being able to be consoled. So with that, you get irritability, excessive or high-pitched crying, excessive sucking, and poor motor coordination. So babies aren't feeding very well. They can have diarrhea, tremors, rapid breathing, hyperactive reflexes, and increased muscle tone. What we had been doing previously to a few years ago is scoring these babies on a withdrawal scale and then starting them on some kind of agonist, either morphine or methadone. Over the last few years, a model has come in for helping these babies, which is called the Eat, Sleep, Console model, which has been great, actually. So this is, rather than going straight to medications for treating these infants, what's been done is many hospitals have implemented a lot more physical support for the baby. So making sure that mom has help in breastfeeding, is doing a lot of skin to skin, having special rooms where the lighting is less harsh, there's not so much noise, limiting visitors, really doing a lot to soothe the baby prior to going to medications. And then asking 3 simple questions. Can the baby eat? Can the baby eat an ounce at a time or breastfeed effectively? Can the baby sleep undisturbed for an hour? And can the baby be consoled within 10 minutes of starting to cry? And if the baby can do all of those things, for the most part, they don't need to have morphine and they don't need to have any medications. And this has been a really successful program. I don't know if I have a slide. I don't have a slide on how much this has decreased morphine use in our area hospital, but it's been pretty profound. This has been a very, very useful approach to caring for these infants. One thing I will say is that we're seeing beginning to see a spike in babies who need who do end up needing morphine or some other kind of medication with the increase in fentanyl that we're seeing in pregnant patients. Fentanyl does tend to have a more significant withdrawal pattern for infants. So next I'm going to talk about alcohol use disorders in pregnancy. So like I mentioned earlier, unlike most drugs of abuse, alcohol has very clearly been defined as a teratogen, and there is no safe level of exposure that's been defined. So this is kind of a difficult discussion, I think, a lot of times, because we have such social acceptance of alcohol and just the idea that you can use small amounts is okay during pregnancy. And it is interesting how our social perceptions really change the risk of perception of alcohol, because really this is the one drug that we know causes birth defects, like unequivocally, this is what happens. Yet we still have a lot of societal acceptance around it. So this was an article from the New York Times editorial in 2019, Why Warning Pregnant Women Not to Drink Can Backfire. Harsh measures or even threats can lead to avoidance of prenatal care entirely. Dr. Roberts has 2 suggestions for what might work better. First, start over and go through a rigorous process of engaging with women who drink during pregnancy to find out from them what would help. And second, stop treating pregnancy as a special case when it comes to alcohol. I have some mixed feelings about that. I think pregnancy is a special case when it comes to alcohol. I think absolutely engaging with women who are drinking and finding out what their risk perception is or what's going on with that. But it is certainly a special case. Pregnancy is a time where really discussing the risks is important. So why is alcohol such a teratogen? It readily crosses the placenta and accumulates in the fetus at levels proportional to maternal blood alcohol concentrations. It's a neurotoxin, and if you think about what's going on in the developing fetus, these neurons are migrating to where they should be, and alcohol impedes that process. For the first 2 weeks after fertilization, alcohol is not thought to have severe detrimental effects, so basically an implantation and blastocyst stage, so women who are drinking before they find out they're pregnant, it's very unlikely to have severe adverse effects. But first trimester in particular, it can impede organogenesis, can impede formation of the neural tube and the central nervous system, and brain development can be affected. When they've looked at patterns of alcohol use that are probably most detrimental to the developing fetus, binge drinking and irregular drinking both put the fetus at the most risk. So binge drinking is considered bringing the blood alcohol to 0.08 or about 4 drinks in 2 hours for an average woman. But I think it needs to be emphasized. I mean, again, when we're talking with our patients, it's risk benefit, but really emphasizing the risks I think is really important. And if the person does choose to continue drink, just having, being supportive, but fronting, really making it clear the risks of this substance. So medications for alcohol use disorder. We really have 3 medications that we can use in alcohol use disorder. 2 of them we can't use in pregnancy. Disulfiram prevents the breakdown of acetaldehyde, and probably if a person were to drink and take this medication, you would have a buildup acetaldehyde, which is also a neurotoxin. So we don't recommend the use of disulfiram in pregnancy. Acamprosate is not recommended either because in animal studies it has been shown to interfere with fetal development. Naltrexone can be used. So no adverse fetal developmental effects in animal models. Case series in human pregnancies where naltrexone was used. The studies were done with opiate use disorder, as I mentioned previously, but they showed no increase in malformations. I do use naltrexone in pregnancy, and I use Withdrawal in pregnancy for people who really have severe alcohol use disorders. As I mentioned earlier, really there's almost nothing worse than high-level alcohol use during pregnancy. So I have the risk-benefit conversation with women, and I will usually go to Withdrawal. And then because of the opioid blocking potential, we will. I generally don't use it past 32 weeks, but I have found it very effective for women who just really have difficulty stopping drinking. And so for naltrexone use in pregnancy, starting oral dose is 25 to 50 milligrams daily. It can cause significant nausea. There's a lot of opiate receptors in the stomach, so I will advise them to take it with 2 large glasses of water on an empty stomach. A lot of times I'll co-prescribe Zofran with it and tell them to take Zofran 15 or 20 minutes before they take the oral naltrexone. And usually what I'll do is a test period of a week on the oral naltrexone before going to the Withdrawal, and that's a once monthly injection. And you need to do an oral challenge before doing the injection to assure there's no allergy or severe reaction. And as I mentioned, consideration of timing of the delivery is important so that you aren't using Withdrawal close to the time of delivery. I think I didn't put in my key takeaways, but I think the key takeaways I have when dealing with patients with substance use disorders, really important to think about where they're coming from, right? They're not coming from the same headspace that we as providers are. And so going back to Bruce Perry, who I mentioned earlier in the slides, he has a great phrase with dealing with children who are dysregulated, but I think has a lot of relevance to adults, Regulate, relate, reason. So people who are really scared about being in your office or frightened about talking about something are not going to be able to engage with you in the same way. And I see this disconnect in the hospital a lot, where someone is giving a patient, kind of clear orders, sort of they're reasoning with them, and the person's dysregulated and they really can't, they're not at a place where they can reason. So making sure that the patient's regulated and feels that they're in a safe environment. And that really takes a lot of connecting with someone and really making sure that they feel safe to talk to you about what's going on in their life. And that's hard in a busy clinical practice, but I think creating that envelope of safety goes a long way with being able to engage women in their own healthcare. And with that, oh, there's my key takeaways. The way the brains work. Screening needs to be done in an open, non-judgmental, supportive manner. Really being aware of what your body language is saying, leaning into someone. It is really not what you say, it's how you say it. And that medication-assisted treatment is effective for opiate use disorders in pregnancy, but they're not the only tool. Actually, they're one of the smaller tools that we have. And the whole social context of substance use really needs to be taken into consideration when caring for people with use disorders. And with that, I'll end my talk. Thank you very much, Paul.
It is our pleasure. Thank you so much, Doctor. That was fantastic. What a great explanation. And you provided so much context and presented in such a human way. So we had a lot of good questions came in during your talk that we'll hopefully be able to let you address as we get into that segment with both our presenters a bit later on. So thank you for coming over and explaining all of the top takeaways there as well. That's really helpful.